All right, let's try this again for chapter 11. So we're going to start with slide 7. Immune function and dysfunction. All right, we're going to talk about 3 different words. Immunocompetence means that I have a competent working immune system, and that's what we want. Very straightforward. When something is, if I'm attacked by an antigen, then if I have immunocompetence, then I'm able to eventually fight off that antigen. Immune deficiency means my immune system is just what it says. It's deficient. It's not working correctly. So for some reason I am able to get sick easily. My immune system is low. For some reason, something in my body is not working correctly, whether it be making the white blood cells, thymus, lots of different things. Certain diseases can make my immune system low, and we're going to talk a lot about HIV and AIDS here in just a little while. And then we've got autoimmune disorders, and autoimmune disorders is something I mentioned in the last slides. Autoimmune disorders are when a patient's immune system attacks itself. All right, so instead of attacking antigens, my body attacks my own cells. All right, and there's quite a few of those disorders. And this chapter doesn't go through all of them, but there is a large table in this book that I really want you to pay a lot of attention to, and we'll talk about those too, okay? Slide 8, immune deficiency disorders. There are 2 types of immune deficiency. The first one is primary, and that means I was born with some kind of disorder that makes my immune system not function appropriately. One of the biggest things I can think of there is type 1 diabetes. And type 1 diabetes causes a destruction of the beta cells in the pancreas, one of the islet cells called the beta cells. And those are the ones that produce insulin, okay? So I think you guys may have already went over that. But if not, we'll definitely talk about it, okay? But in my pancreas, I have alpha and beta cells. And my beta cells, which both are considered islet cells, my beta cells destroy themselves, and so I can't make insulin. So that would be something that I was born with. So that's a type of inherited or primary immune deficiency. And then I have acquired immune deficiency problems, and probably the most famous of these is HIV and AIDS. I mean, it's even in their name, acquired immune deficiency syndrome. And HIV, of course, is the virus that causes AIDS. But these are 2 of the biggest things. These are something I acquired later in life that's caused my immune system not to work correctly. Next slide is immune deficiency orders continued. Diagnostic tests and treatment. Let's see here when this is on in your book. This is on page 218, it looks like. It talks about the early stages of autoimmune disorders. Definitive diagnosis may be difficult. Really can't figure it out. Sometimes you just have a general feeling of malaise or non-well-being. So they're just kind of probably looking through to make sure, ruling everything else out. It does say that some patients' immune systems have virtually no ability to respond to antigens because they were unable to produce lymphocytes that are sensitized. That's those B cells and those T cells, all right, that we talked about in those last chapter. My body was unable to make those, so every time that I am subjected to the same antigen, I have the same response, a big response. I don't have those protective cells. So for these people, I could check their blood work to see if they are making these cells. Or I could look at a CBC with a differential and look at their white count and see what's going on there. It also talks about checking their immunoglobulins. Of course, that's what we were talking about before a little bit too. Remember, immunoglobulins are the same as antibodies. So there's some tests that I can do, blood tests, to see if I'm actually carrying antibodies. And if I don't see any antibodies, then I know that I've got some kind of immune deficiency problem here. Let's see what else we have in the book. And remember, if I cannot make certain antibodies, I can always give those in the form of immunoglobulins through an IV. Okay. There is a box at the top of 11.3. On page 218, it says examples of diagnostic tests to detect an autoimmune disorder. CBC, of course, we said a red count, and your red blood cells, remember, are your hematocrit and your hemoglobin. Hematocrit being a good way to figure out exactly how much red blood cells I'm carrying. It's kind of like my numbers. And then my hemoglobin is the red blood cells that carry the oxygen. Creatinine level, anytime I hear of a creatinine level, I'm going to think of kidney. Okay, so creatinine is, if I draw it in your blood, it's going to tell me how well my kidneys are working, because my kidneys should be getting rid of waste. All right. And if they cannot get rid of waste, then it's going to be backed up into my blood. So I can do blood tests and urine tests to determine how much waste that I'm actually still keeping in my body. An anti-nuclear antibody test is a very important one. You'll see that a lot in testing for autoimmune disorders. It's a blood test. It's not definitive, but it gives you a good idea. Bone marrow studies can let me know exactly how well my bone marrow is functioning, to let me know about my white count. I rely on my bone marrow to help me make blood cells. Serum protein electrophoresis, immunoelectrophoresis, T and B cell counts. That's very important. The three right before that, I'm not too concerned that you know. But if I look at my T cells and my B cells, I can definitely understand if I'm able to make those protective antibodies. The next slide is HIV and AIDS. There's HIV-1 and HIV-2. All you really need to know about that is HIV-1 is usually what we see here in the States, and HIV-2 is usually around in Africa. There's a high population of people with HIV-2 in the African continent, but it's a slower moving AIDS. A slower moving virus, HIV, than in number 1 is, and that's the one we usually have here in the States. It's a little bit different. We say virus, but it's actually considered a retrovirus, and retroviruses are like viruses on steroids. So a normal virus, like COVID-19, will hijack your cells.
That's not a normal virus.
Well, not a retrovirus, just a virus. And my daughter's right, it's not a normal virus. It's a bad boy. But it's not considered a retrovirus just yet, all right? So viruses come and go, okay? So if we get a virus, we have it for a little while and then it leaves. But retroviruses don't, and here's why. And
not gonna leave.
Well, I hope it does. In a normal virus, you'll get the virus. It kind of hijacks your cells, takes over for a little while, mutates, and then it leaves, okay, in a nutshell. A retrovirus carries its own RNA, okay, and it goes into our cell's DNA and starts to replicate. So it takes over the cell. And it does that by the help of an enzyme called reverse transcriptase. And all you really need to know about reverse transcriptase is it's the enzyme that allows the retrovirus to take over the cell. And as my cell replicates, it's replicating cells that are just like itself, that have the retrovirus attached. So at that point, although those cells that have been invaded by the retrovirus and will now be making cells, absolutely, but it'll be cells that already have the retrovirus, the HIV, embedded into their genetic makeup now, because the RNA from the retrovirus decided it was going to take over my DNA. Okay, so it's not hijacking the car anymore. It's kicking your butt out of the car, and it takes over the cell from now on. Transmission of HIV is pretty much what you think of. The 3 highest risks, of course, is having unprotected sex, whether that be oral, vaginal, or anal. All of those things introduce you to secretions or blood or something along those lines. So having unprotected sex of any of those ways with an HIV-positive person. Of course, sharing needles and syringes with an HIV-infected person. That could also be a needle stick for healthcare workers, for people who have HIV or AIDS. It doesn't have to be just sharing the needles. It could be a large bore needle stick, and we'll talk about that later. And then there's maternal fetal exposure. So those of you who got to see childbirth, you understand that there's lots and lots of blood and body fluids involved in childbirth. So some big things to remember about those people who are taking care of the baby is we don't want to do any injections until the baby's clean, because that will expose a break in the skin. Try to wipe away anything from the mucous membranes as quickly as possible. There are some experts that say people with AIDS cannot breastfeed because it is exposed that way, and some say it's okay. I think the jury's still out on that one. I'm not really sure. Everybody has an opinion. But definitely during childbirth exposure. Other possible risks are a little bit lower: tattoos, body piercings, and blood products. Most places, or they should, all places, I don't know if they do or not. It's been a long time since I got a tattoo. But tattoos and body piercings, either they break new needles or they should be autoclaved, but I don't know that you can ever be definite unless you watch them break the new needles in front of you. And then the blood products, like receiving red blood cells or whole blood or something along those lines, they go through rigorous testing, but it's never an absolute. All right, there's always a slight possibility, but very slight. The next one's exposure prophylaxis. The only prophylaxis medication-wise that I'm aware of is this Truvada. There may be more out there now since these slides have been developed, but Truvada's all over the TV. You can see commercials for it. It's for people to take whose significant other has HIV, and they can take that and still be intimate with their partner, and it's supposed to keep you from getting it. But the best way, of course, to not get HIV or AIDS is to not do any of those high-risk activities with someone with HIV or AIDS. If you do have a partner with HIV or AIDS, make sure you're practicing safe sexual practices. Blood products, we're just touching on there too, but blood products, again, are very low risk now, but not no risk. And then vaccination development, I suppose they're still working on a vaccination development. I don't know how long that'll be because we started seeing HIV and AIDS in the 80s, and of course back then it was pretty much a death sentence. But now there are lots of medications out there that can slow or halt the process. And as of this past few months, there is some countries saying that they have found a cure to AIDS and have actually cured the first couple of people of HIV or AIDS. I can't remember which one it is. But before that, we could give you plenty of medicines to make your viral load very low, okay? And when I say viral load, I mean the amount of virus that's actually circulating in your system, making itself known. And we could give you medications to suppress those in so much ways that if we drew your blood, it was almost undetectable. But we would see if you stopped taking those medications, then your viral load would raise. And of course, the higher your viral load is, the more able you are to spread it to another person as well. But, of course, this new drug, whatever they're using now, is supposedly cured 2 people of HIV, or AIDS, I can't remember which one, but, as of in the States, not just yet. Now, lots of people like Magic Johnson, who has had HIV for years and years and years and years, is doing quite well. And that is because he has got all those drugs that have kept his viral load very low. Signs and symptoms of HIV or AIDS can be very vague. You may not have any symptoms in the beginning, and that's the latent part of the disease process. And then we might see a development of flu-like symptoms, achiness, night sweats, fevers, unintentional weight loss, things of that matter. They can be quite vague. And the reason we start looking for HIV or AIDS if we have a sentinel infection. And a sentinel infection is usually another name for opportunistic infections. And opportunistic infections are just what it sounds like. Something sees that your body is not functioning at top peak level, so they take that opportunity to make you sick. And most of the time when we see opportunistic infections, there are things like fungal infections, like yeast in the mouth, or yeast infections. So all people that have taken, especially girls who have taken lots of antibiotics before, and we've said earlier, antibiotics make your immune system drop, and then your body's own normal flora can take over and cause yeast infections, and that is an opportunistic infection, okay? So the reason we start looking for HIV and AIDS is for people who have reoccurrent sentinel infections or reoccurrent opportunistic infections. The diagnosis, on the next slide, on slide 14 for HIV and AIDS, there are a couple of tests that you can do at home. I've never seen those in person. It says here that they're called OraQuick, but I did read in the book, though, that it does say that people who are positive or negative should follow up with their MD, just in case that was a false negative, and of course if it's positive, for next steps. So to me, what's really the purpose in doing that? The ELISA test is the faster of the tests. It comes back pretty fast. It kind of gives you, we kind of call it a rapid HIV. So if I wanted a fast test, I could do that. And of course, if that comes back positive, then I want to confirm it with a Western blot. Next page is management of HIV and AIDS, and it talks about your CD4 lymphocyte count. Now, your T helpers carry this protein on their surface called CD4. And you may have seen this in some HIV medication commercials or something along those lines. But my T helper cells carry this CD4 protein, and this is very important because remember, my T helper cells are really pushing my B cells to work and pushing my other T cells to work. So they're quite important. But in this disease process, my CD4 T cell count goes dramatically down. And of course, I'm unable to fight any antigens that come on board because I don't have these T helpers or these T CD4 cells helping me out to boost my immune system. The highly active antiretroviral therapy or HART therapy, all I really want you to take from ART therapy, ART is antiretroviral therapy. Because you may see this HART therapy, you may see it as CART therapy. And I always like to think of it as CART therapy. Just depends on the types of medications that are in there. Just depends on the book that you read it out of. But what I want you to know about antiretroviral therapy for these people is that it's massive amounts of drugs taken for the rest of your life at least 90% of the time correctly. And that is forever and ever and ever. If you don't take them correctly, at least 90% of the time, they are useless. And this is for the rest of your life, okay? As of now, as of current state of medications. So you'll at least see the ART part, antiretroviral therapy, but you may see the HA in front of it. You may see a C in front of it. Think about a cart full of medications you're pulling along because that's what it is. Lots and lots of medications forever and ever. This is Kaposi sarcoma, and this is one of the things that you commonly see in people with HIV or AIDS. The progression, of course, AIDS being what you get after HIV. HIV is the virus that causes AIDS. So a Kaposi sarcoma is, and when you hear OMA, you usually think of cancerous. And this is a malignancy of people with HIV, and it causes these discoloration, raised areas. Sometimes they're flat, I think, but a lot of people end up with them all over their body. I think a lot of times, depending on how advanced the current state of condition is, they may or may not treat them. I think you can do chemotherapy, maybe even radiation for them if they're bothersome, if they start to spread. But these are typically seen on the skin. So read a little bit more. I think there's a small area about Kaposi sarcoma in here. Let me see here. Kaposi sarcoma is under neoplasms on 228. Okay. So hopefully the ART therapy that these people are taking will suppress these Kaposi sarcomas, but they are quite common in people with AIDS. Cultural considerations, factors that increase the incidence of HIV infection and progression to AIDS among minority groups. Lack of culturally sensitive and high-quality information about HIV risk and prevention. If people don't know about it, they don't know how to prevent it. All right, so places that might have, this goes to socioeconomic a little bit too, communities that have not as much health care provided, they might be low income, other ethnic groups, there might be a language barrier. We need to make sure that the literature is getting out to the people in whatever language that they speak. We need to make sure that these people have access to health care, which can be a huge thing in America. But when it comes to cultural and socioeconomic, we have to make sure that the people who might be most likely to get it are the people who don't understand what it is. So we need education out there. We need groups of people going out and making sure that people have literature and educating people on how what this disease is and how it's spread. Health beliefs concerning sexual practices, role of women, value of children, HIV treatment. A lot of that goes back to maybe even some religions. Some religions don't believe in protection with sex. They don't believe in any kind of birth control, including condoms. So that's another reason it could be spread. And some people don't believe in taking medications as well, and that could go back to cultural. So you need to make sure that when you're taking care of patients with HIV or AIDS, that you're understanding exactly where they're coming from. And also, we can't talk about this without talking about the huge cost of the antiretroviral therapy. And fortunately, a lot of companies out there will help you get your medications if you're unable to get them. And usually that's the companies who make the drugs themselves. So that's something good to remember. And also your whoever is working on your floor as a case manager should also know these things as well. We're going to skip 18. That's a question. All right. I do want you to look in your book, though, because this question does say about breast milk. And I want to look in your book and see what this breast